Good afternoon, and welcome to this afternoon's Colorado Medicaid Innovation, Sustainability, and Opportunities webinar with representatives from the Colorado Governor's Office, the Department of Health Policy and Finance, and Manat Health. My name is Barrick Abramson with Confluence Policy and Strategy Group. We appreciate you joining us this afternoon. Next slide, please. American Sign Language and Spanish interpreter services are available by selecting the globe icon or interpretation pod on your Zoom toolbar. Links will be posted in the chat, but the chat will otherwise be closed today. Materials, including the meeting recording, will also be posted after the webinar to HCPUF's website. Please do use the Q&A feature on the Zoom toolbar for questions about the presentation by Manat today. Thank you for the engagement today. Next slide, please. Manat Health Strategies recently conducted an analysis of Colorado's Medicaid and Child Health Plan Plus program cost drivers and compared these trends to several states. In addition, Manat is analyzing several options for potential short and long-term policy changes to improve the affordability and sustainability of the Colorado Medicaid and CHP Plus programs. During today's webinar, experts from Manat will share more information on the study, review findings from the landscape analysis, and preview additional policy options being evaluated. This will be an opportunity for everyone to understand more about this project and begin the process of gathering feedback from stakeholders on potential policy changes. I do want to emphasize, today is the start of that engagement. We'll be spending time with Manat sharing the findings of their landscape analysis, followed by a very high-level look at some of the policy options developed. Stakeholder engagement and conversations with all of you will continue and will resume in the first quarter of 2026, but we wanted today to begin laying the groundwork for some of those conversations. We do have Spanish interpretation available, and for that, we have Julieta. To access that translation, click the globe icon.
Buenos días, mi nombre es Julieta y brindaré servicios de interpretación en español. En un momento este servicio estará activado. Para escuchar la interpretación en vivo en español del evento de hoy, seleccione el módulo Interpretaciones en la barra de herramientas de Zoom y luego seleccione Español. Tendrá la opción de seleccionar Silenciar audio original si desea solo escuchar español. Este módulo de interpretación se activará momentáneamente.
Thank you very much. Today's presentation will feature remarks and presentations from Mark Ferrandino, Director of the Office of State Planning and Budgeting, Kim Bimestafer, Director of HCPUF, Kevin McAvee, Managing Director at Manat Health, and Melinda Dutton from Manat Health. With that, I'm happy to hand it over to Mark Ferrandino from OSPB.
Thank you, Barrick. As Barrick said, Mark Ferrandino with OSPB. Thank you, everyone, for joining us for this conversation. Really appreciate the interest. We know this is a difficult conversation as we looked at the state's budget and continue to see the growth within the Medicaid expenditures far outpacing both the Tabor cap as well as available revenue. We knew we had to do something to try and address the shortfall. That's why through executive action, given the impacts of HR 1 and the loss of revenue, we made some tough decisions to slow the growth of Medicaid. And that's why also in our budget submission on October 31st, we continue to move down that path of trying to slow the growth of Medicaid. We know this is not an easy conversation. One of the things we do know is we know what we know, but we don't know everything. And that's why we thought it was really important in partnership with HCPUF to bring in Manat to be able to get an outside perspective on the work that is happening and how we compare to the rest of the nation in where we're seeing cost drivers. We really want to make sure we're making the smart decisions now so we can avoid really drastic, hard decisions long-term. Small changes and other things now will allow us to slow that growth of Medicaid, get us into a more sustainable path, and make sure that we'll be able to provide the services that we know are needed all across our state. We picked Manat because of their huge expertise and national reputation on Medicaid policy. And I think you'll see today as they walk through their understanding and depth of knowledge of this. And I really appreciate their partnership and the partnership of the staff at HICPUF who've been able to put this together in partnership. And with that, I'm excited to turn it over to Kim Bimsteffer to share some thoughts.
It's Director Ferrantino, that I really appreciate you joining us today and your leadership through this whole project. So it's been really tremendous. Let's go to the next slide there, Kelly. So good afternoon, everybody. I just want to clarify what's the problem we're trying to solve in addition to Mark's spectacular comments there. So our trend over the last 4 years has been running in the average neighborhood of about 19%, which is clearly unsustainable. But the trends in previous years have averaged about 6%. So we know we can get back to that place because we've been there before. So I want to thank you in advance for your collaboration and your partnership, for everybody getting in the boat and rowing towards a better tomorrow with a more sustainable trend for all the reasons that Mark said. So let's go to the next slide, please. So the good news is we have a plan. It's the Medicaid Sustainability Framework. I also want to thank you in advance for your partnership and collaboration through all the stakeholdering we've had on the reductions that we've put forward already. So what's the objective? These 6 pillars, really look at those trends, where they're coming from, and address them to get them more in line. To pull down federal monies as one window closes, how do we open up another door to get those monies coming in? Back on number 4, also on trends, where we put in a policy together and it's not getting the outcome that we wanted. In fact, maybe it's having an outlier outcome. How do we adjust that to get back to what we intended to begin with? Number 5, reassess new policies, really make sure we're using these next few years to get our trends under control before we add more things on, and exercise tremendous caution in that area. And I should say reassess policies where we put them in and now we realize we can't afford them. We might have to delay or pull them back a little bit. Let's go to the next slide, please. So we promised a comprehensive approach. 1, that sustainability framework. 2, recognize HR1 and its impacts, do everything we can to keep people on the rosters, but also really tackle those impacts with investments, eligibility advances, etc. Leverage ACC Phase 3. It went in July 1. But timing is just spectacular. The innovations and the additional cost controls, we really need to leverage all of those. Transparency and engagement and conversation like these, but all the other stakeholder meetings. And the most important part of today's meetings, we promised to bring in that third party that Mark just represented. And I want to thank Adela Flores-Brennan for her tremendous leadership in running that whole RFP process. If you want to see what that statement of work is that Manat won and is now working through, you can link onto that, which we'll put in the chat, but we'll also have this slide with the attachment of that statement of work that you can look at when this recording and the slides come out to you in the coming weeks. So with that, I will turn it over to Manat and enjoy the presentation. They've taught us a lot. We're excited to have them as a partner, and thank you very much for being here today.
Thank you so much, Kim. And Mark, thanks for the introduction. My name's Melinda Dutton. I'm a partner at Manat. Manat Health is a law and consulting firm. I lead our state transformation practice. What we do is work with states all across the country trying to help strengthen their Medicaid programs for people who depend on Medicaid for their health coverage. We feel very lucky to be working with you all here in Colorado. We know these are tough problems, and we have been really impressed and felt a very productive working relationship with HICPUF and with the governor's office on this, and are excited to be getting some stakeholder feedback on this work. So let's go through our agenda today. Next slide, please. I'm going to start with some opening comments that describe the broad approach and purpose of our work together. I'm going to give a little bit of background about the big picture that we're working within, and then I'm going to hand it off to my colleague, Kevin McAvee, who's going to introduce himself at that handoff. And we're going to spend most of our time on this third bullet, the Colorado Medicaid Landscape Analysis. This is the bulk of the work that we've done today, to date. And then we're going to talk a little touch on the policy strategies that we're starting to explore and next steps at the end. Let's go to the next slide, please. Okay, project purpose and approach. Next slide. As Kim and Mark described, we have a very clear task before us here. We are to identify both immediate and long-term cost-saving solutions that will better enable Colorado to improve the effectiveness and efficiency of its Medicaid and CHIP programs while achieving the quality and access goals. So in short, we're trying to preserve the value and commitment to the Medicaid program while ensuring its long-term sustainability. Let's go to the next slide, please. The project has three main phases. We're going to talk mostly about this first box, which is our landscape analysis. And I'll talk a little more about what that looks like in a moment. But we started at the big picture, looking at Colorado, comparing it to national and state level comparator state trends. And then from there, we look for hotspots. Where do we see outlier places where it looks like Colorado may be out of step in terms of costs or outcomes related to different parts of their program. From that, we started to identify some policy actions. We're in the early phase of that, and we'll be talking more about those in future webinars. And then ultimately where we're going to turn is we're going to narrow down those policy options and do some financial and implementation analysis to help prioritize which of those policy options are most promising for the state. I want to acknowledge that we're doing this in the context of a moving target. We know that the governor and the Department of Healthcare Policy and Financing have concurrently been promoting and enacting immediate program changes. We are acknowledging those in our work as we go along. We're not going to try to replicate or repeat what those changes are, but are really trying to focus on value add additional changes that are high potential for Colorado in achieving its goals. Let's go to the next slide, please. This gives a visual of the kind of narrowing process that we have undertaken here. As I said before, we started with the very highest level, the comparative state analysis. We looked at national data and we looked at comparator state data. This is publicly available data so that we could do kind of apples to apples across the country and really look for, where's there smoke here? Where do we see that there are trends or numbers that surprise us compared to national and other state trends? Then we double clicked. When we found some areas that looked surprising to us, we went into the, in partnership with HCPF, went into the Colorado specific data. So we were able to go in and look at cost growth trends with more specific information that was directly relevant to the Colorado's program. And then from that, we have started to identify some opportunities for policy actions that could address some of those trends. Ultimately, as I said before, we're going to narrow this down to a small number of policy actions that we'll do financial and implementation analysis on. Next slide, please. In very broad terms, as Mark pointed out, you've got a limited number of levers within your Medicaid program to try to control costs. And the first three of those levers are very blunt instruments: cutting program eligibility, reducing services that are covered, cutting payment rates. This project is focused on the fourth lever, which is maximizing value within the program. This requires getting really in under the hood. There's no one magic bullet that's going to solve all the healthcare cost problems and cost growth problems in Colorado's Medicaid program. But through looking deeply under the hood here, our hope is that we can find some more nuanced, sometimes more complex sets of solutions that can preserve the commitment to the program while getting more value and reducing cost overall. So that's really our focus, is that fourth bucket. Next slide, please. Okay, I'm going to say just a few words. We can go to the next slide about the big picture, and then I'm going to hand it off to Kevin to dive into the data. I just want to acknowledge upfront that the Medicaid program in Colorado and across the nation exists within a larger healthcare system that most experts believe is fairly flawed. Inefficiencies in the U.S. healthcare system are really well documented. Researchers estimate that up to about 25% of our spending is wasteful. We spend about twice as much as our comparator countries do on the cost of medical care. And those inefficiencies are driven by a variety of factors, including the fact that our negotiation and pricing regulation is so disparate across so many different payers, the fact that we have a lot of administrative complexity in our program. Some estimates are that 30% of that inefficient spending is just shuffling paper and administrative costs related to our system. And then, of course, there's been a lot of talk especially in recent years, about the fact that we have a thinner social safety net than many of our comparator countries, which makes it harder for us to get upstream and prevent more complex and expensive healthcare needs down the road. This is inherent in the US healthcare system, and Medicaid can impact some of these levers, but those not all of them. And the larger healthcare system, larger healthcare system change is beyond our full scope. Let's go to the next slide. We also want to recognize that within the context of Medicaid, all states are struggling with their Medicaid budgets. Medicaid is a large share of every state's budget, and it particularly in times of economic retraction, funding the Medicaid program is a source of stress and concern. In the context of Colorado, the Taxpayer Bill of Rights makes those challenges more immediate and provides more urgency to the problem before you. So we want to acknowledge that that's also a constraint that you all are working within that isn't unique, but is magnified in the state of Colorado. As I said before, healthcare costs are expensive. They're growing faster than wages over time. And they're driven by a combination in the Medicaid context of the underlying costs of medical pricing, but also the population growth. So those two things can really put pressure on state budgets overall. When you add on top of that HR 1, which we all know are going to bring new cost pressures to the Medicaid agencies, there really is a sense of urgency around trying to identify opportunities for better value and efficiency within the program. Let's go to the next slide. Want to point out that while healthcare spending overall is going up. So this is a chart that breaks out by payer the rate of growth of healthcare spending. So that the top line is private insurance, the next is Medicare, the bottom is Medicaid. Medicaid in general is the least expensive form of health coverage in the US. It's in part driven by the fact that the payment rates to providers are lower, that tend to be lower than other payers, but it also has a slower rate of growth than other forms of coverage. So while we're wrestling with our bringing Medicaid under control, want to acknowledge up front that Medicaid starts in a place of being a pretty efficient provider of health coverage. That requires us to really dig in deep to find those areas of further efficiency. Next slide, please. And then finally, wanted this on focusing on the left-hand side of this slide, you can see how the comments that I've described kind of come to light. Medicaid spending on the left for the period between 2019 and 2024 has been at 7.9% annual growth, whereas TABOR, it's been at 4.5%. TABOR and Medicaid growth are while TABOR is the cap that is limiting on your state, what drives the factors that drive Medicaid growth are really unrelated to the factors that control your TABOR cap. So the number of people enrolled in Medicaid or the cost of medical care or the mix of acuity of the people enrolled in Medicaid are untethered from the CPI measure that drives TABOR and the state population measure that drives TABOR. So this is yet another reason why it's really important to drill down into the program and look for those value opportunities. Okay, I'm going to hand it off now to my colleague, Kevin McAvee, to walk us through the landscape analysis.
Thank you so much, Melinda, and thank you all so much for having us. My name is Kevin McAvee, and if we go to the next slide, I'm a managing director at Manat Health, and I have the privilege over the course of the past probably 20 years now of working with health data in varying forms, from claims and encounters, clinical ADT data, financial data, to inform federal and state policy making and decision making in pursuit of a North Star of achieving a more accessible, affordable, efficient, and effective healthcare system for every American. In short, I really seek to provide facts for all stakeholders to make data-driven decisions. And it's been a privilege to support Colorado as part of our broader team and in partnership with HCPF and the Governor's Budget Office in placing Colorado's Medicaid program costs and cost growth and program performance in context with national and peer state or comparator state trends. So if we can go to the next slide, I want to talk and start a little bit and ground us all in some of the work that we've been doing over the course of the past few months. Over the course of the past few months, we've reviewed over 75 reports and data sets, materials provided by the state, conducted nearly 20 interviews with state subject matter experts to identify and contextualize landscape analysis, the findings of which we're going to start sharing with you today. We also leveraged federal and national data sources to support analyses comparing how Colorado is doing to other states and national trends. For example, throughout the reporting today, you'll see several analyses based in what's known as the CMS 64 reports, which are standardized expenditure reports submitted by all state Medicaid programs. We also relied heavily on data compiled by MaxStats, and as well as where those data had limitations, we turned to state data sources for both more timely information and deeper information on what's going on within Colorado Medicaid. These include HCPUF's premiums, expenditure, and caseload reports, which are publicly available. These essentially, if you want to think about them, they provide Medicaid spending across service categories and enrollment across populations at a much more detailed level that might otherwise be available through national and federal statistics. We relied upon the JBC appropriations reports, which are produced every fiscal year. These are definitive data sources capturing state appropriations across departments. We also, where necessary, really dug into some aggregated claims and encounter data for more granular spending and enrollment trends. Again, throughout this process, we didn't just want to rely on pure cold numbers. We really sought more information from our state counterparts to really contextualize it, to understand, and also to verify trends that we were seeing. If we can go to the next slide, though, I want to spend a moment on actually talking about data. I mean, we could talk about this for a long time, but I know I'm going to get nudged if I linger too long in it. But it's really important for us all to understand what data tells us and also what data does not tell us. While publicly available data often allow for standardized and ideally cross-state comparisons, they do have notable limitations. And some of those limitations we wanted to outline and just kind of remind us all of here. That data timeliness, some of our metrics of interest might not have been available for data sources through 2025. Data availability, the questions we have might not always have a data source available to us to get to a complete, fulsome, or targeted answer. Data accuracy, we have to always understand the data, where we're pulling that data from, and verify it to make sure that we are using the most accurate data possible to inform some very important decisions. And data comprehensiveness. We have to often braid or pair data to get a real sense, a real full reflection of the world. And we did that here. And as mentioned, where public data sources came up short, we worked with our state partners to pull in supplemental data files and also use data from the states to validate trends and address anomalies we may have otherwise observed. So let's get into it and actually talk about what we found. So total Colorado Medicaid and CHIP spending writ large has increased by about 60% since state fiscal year 2018. This is about, if you want to think about it on an annual basis, around 8% growth per year. This exceeded, as Melinda mentioned earlier, greatly exceeded the average annual TABOR growth rate. And increases in Colorado's Medicaid spending have, while they've mirrored national and comparator state trends, when you bring in the TABOR constraint, it can potentially crowd out other state spending options. Recent growth in recent years has been driven, in Medicaid spending has been driven by increasing prices for Medicaid services, growth in Medicaid enrollment, particularly through the COVID-19 public health emergency and the pandemic. And the state currently projects Medicaid spending growth to persist in the coming years. One other note on this slide, as you'll notice between the two bars, the lighter blue on the top and the darker blue on the bottom, is this split between state and federal funds, as Medicaid itself is a state and federal partnership. Accordingly, it's the financial contributions to these programs are also split up. I will get a little bit more into how these contributions are made, 'cause it's really important to understand the financial realities of any Medicaid program, particularly in Colorado, in another two slides. But I did want to call out the state share, which was about in aggregate around 43% in 2025, and that's what we're going to be focusing on the next slide. And if we can go there. So Colorado's state share of Medicaid costs have grown in tandem with overall spending growth and is generally sourced from a couple of different funds, primarily the general fund, which many of us are aware of, as well as cash funds, and then a small amount from reappropriated funds. The share of Colorado's state-funded budget attributable to Medicaid has grown in recent years, with Medicaid and CHIP appropriations comprising around 22% of Colorado's total state-funded budget in the state fiscal year 2025. This, for a reference point, because I always find that to be useful, compares to about 19% of the state-funded budget in 2020. Looking ahead, Colorado's ability to support a growing Medicaid and CHIP state share will likely be further constrained by new challenges for raising general fund and cash fund revenues. On the general fund side, as we've spoken about before, and we'll reiterate a couple more times, it really will be limited by TABOR. On the cash fund side, the passage of HR 1 frequently at the One Big Beautiful Bill Act will limit Colorado's ability to collect new cash fund provider fees to fund programs and benefits while increasing program administrative costs due to new eligibility and work requirement rules. If you go to the next slide, I just wanted to take a moment to talk about this federal-state partnership and place Colorado in perspective here to many other states across the nation, a number of which we're going to be referencing through subsequent slides. Colorado's Medicaid spending is also constrained in many regards by its lower FMAP. A state's FMAP, or Federal Medical Assistance Percentage, governs the proportion of Medicaid benefit and service spending that's covered by the federal government versus what's owed by the state. Some states might have, like the richer states might have a 1-to-1 ratio where the state contributes $1 and the federal government contributes $1. Other states might benefit more from a 2-to-1 match or even more from the federal government. Colorado, for better, is a wealthier state. Wealthier states have lower FMAPs, and Colorado's FMAP is among the lowest nationally at only 50%, while the national average, as you'll see, like in an orange line over there over fiscal year 2025, is around 60%. This means that Colorado is responsible for covering 50% of all state service spending for traditional Medicaid populations, while other states might only be responsible for covering a smaller amount than that. Small FMAP changes can result in big and significant differences in the amount of state share that's responsible. And just one anecdote here, for example, if $100 in medical services are reimbursed at a 55% FMAP rate in a given year, it would cost the state $45, with the remainder being reimbursed by the federal government. However, the same service costs reimbursed the following year at a lower rate of, let's say, 50% FMAP, as we saw between the public health emergency and later years, would cost the state $50. So the state's cost would move from $45 to $50. That might not seem like much, but that in and of itself, holding everything else equal, medical costs equal, which all of us know to be a little bit of a fantasy, results in a state expenditure increase of more than 10%. While a low FMAP constrains Colorado's federal share of funding, TABOR constrains the state's share by making it harder to raise revenues. All in, Colorado has a low FMAP because it's a relatively wealthy state, but it has the resource constraints often of a poorer state due to TABOR. Next slide, please. On the next two slides, we'll look at some of the biggest drivers of Colorado's total medical spending growth. The figure on the left, and I'd encourage you to focus there and take a minute to think it through. shows the cumulative percentage change in Colorado's overall Medicaid benefit spending and spending on specific service categories between state fiscal year 2019 and 2025. For those who aren't visually inclined or can't see the numbers, like I can't anymore, there's a table on the right-hand side that spells it out. In total, overall, Colorado's total Medicaid benefit spending increased by approximately 67% over this time period. And this is just to note spending on particularly Medicaid benefits. We're putting administrative costs aside. And you can see from the figure that spending growth on some of these service categories, including things like long-term services and supports, behavioral health services, and prescription drugs, have outpaced overall growth in overall Medicaid spending. If you're looking for the overall Medicaid spending line in this graphic and the ones that follow, you'll see it as the black line that's dashed throughout. And we'll talk about and pull through this presentation a little bit more information about each of these components of spending growth over the coming minutes. The other category, which I just wanted to note, is not a small category. I think if you look at the second column and total benefit spending, we're talking about $2.8 billion here. It includes things like dental, labs, imaging, managed care plan, capitation payments. It's a significant category, but it's not the focus of our findings today. But I didn't want to go too far without calling it out. Next slide, please. I also didn't want to go too far without calling out two other additional service categories, which, while they make up a small percentage of our overall healthcare cost centers, they comprise a they showed a significant amount of growth. These two services are non-emergency medical transportation, or NEMT services, as they're commonly referred to, as well as pediatric behavioral therapy services, or PBT services. These services, again, have lower overall relative spending relative to the services we saw in the last slide, but these are areas where Colorado has seen dramatic spending growth in recent years, with spending increasing around 471% and 436%, respectively. We'll dive into PBT a little bit more in a second. We won't be reapproaching in this conversation NEMT, but I didn't want to skip it over or let it be ignored. It grew from around $53 million in state fiscal year 2019 to $288 million. And like with many of these other trends, while we did bring a third-party external lens to this analysis, these are areas where many of these areas are areas that have been identified by the state, in which the state is already starting to take significant action to curb cost growth. NEMT is very much included in that. HCPUF identified this increase early and is already starting to see the fruits in some of the new checks they put in place, with NEMT spending beginning to decrease between 2024 and 2025. If we go to the next slide, I want to call out this difference between cost centers and cost drivers. In the pie chart on the left, you'll see an outline of cost centers within Colorado Medicaid's benefit service spending. These are benefits that make up a sizable proportion of total Medicaid benefit spending. This is where you'll see long-term services and supports, which comprises 35% of overall Colorado Medicaid benefit spending. This, I want to note here, and I'll note it again, is not an anomaly compared to many other states. Medicaid is the payer of last resort and a primary payer of LTSS services nationally. Cost drivers, if you look at the second pie chart, are where benefits are growing at a rate that's disproportionately high over the time period we examined, which in our case is 2019 to 2025. And here you can see, if you can see, lean in on your computer. You can see LTSS is Colorado's largest cost center and cost driver, accounting for over 35% of the state's total Medicaid benefit spending in state fiscal year 2025 and over 42% of the state's total Medicaid benefit spending growth between state fiscal year 2019 and 2025. But it's not alone. There are other major cost centers and cost drivers. These include behavioral health services, pharmacy, PBT, as I previously mentioned, and even NEMT, although smaller as a cost center. Let's actually talk about these one at a time. If we can go to the next slide. I'd like to move on to some of our findings from some of our deeper targeted analyses in each of these areas, just to give you a sense of the depth of the analysis that we did and provide a little bit more policy and program context to each of these areas. So behavioral health. Just to take a step back, Colorado's regional, for those who might not always be familiar with each area of our Medicaid delivery system in Colorado. Colorado's regional accountable entities, or RAEs, are responsible for administering the state's capitated behavioral health benefit. All Medicaid enrollees are eligible for behavioral health services, and the RAEs receive an annual payment for each member to cover the costs associated with these services. There are some behavioral health services covered outside of the capitated benefit, but it's really narrow. 98% of all of Colorado's behavioral health spending is attributable to these capitated payments to the RAEs. And from 2018 to 2024, spending on these capitated behavioral health benefits outpaced growth in the number of individuals utilizing these services. In effect, the cost of actually serving utilizers went up significantly. Behavioral health spending now accounts for approximately 8% of total Medicaid benefit spending, with total spending now exceeding $1.2 billion in state fiscal year 2025. Again, to call a reference point, in 2019, it was only $603 million, doubled over that time. So what are the cost drivers? Part of the growth in behavioral health spending, based upon our analysis and the conversations that we've had, the research that we've done since state fiscal year 2018, 2019, were in part intentional. I mean, as many of you know, stakeholders on this call, the state has made intentional investments to expand access to new services, particularly for those with substance use disorders. For example, the number of behavioral health providers contracted with RAEs or managed care plans nearly doubled between state fiscal year 2020 and 2023. To get to specifics, increases in behavioral health spending have largely been driven by the volume and costs of services rendered. Between 2022 and 2024, spending on outpatient prevention and treatment services increased 30%. Spending on community and peer support services increased about 52%. Concerted efforts during the Accountable Care Collaborative Phase 2 have expanded the state's independent provider network and associated spending, with spending attributable to those providers increasing about 75%, again, over that 2-year period of 22 to 24, nearly doubling over that time. This is a trend that showed up using both our external data and our own independent analysis of HCPUF's data, and is a trend that was identified by HCPUF, in which it's actively monitoring and responding to, as both the director and Mark previously mentioned. Their immediate actions have included exploring new network management policies to strengthen accountability, reinstituting some prior authorizations for services, and instituting new policies to ensure the integrity of peer support services. This is one area that really showed up to us as a cost driver. If we go to the next slide, another major cost center and cost driver, as we were previously discussing, has been long-term services and supports. Colorado is not alone here, but Colorado is where we're focused right now. Colorado has made significant and similarly intentional investments in LTSS in recent years to shift care and service delivery from institutional to more efficient and cost-effective home and community-based settings, and to strengthen the workforce that supports Coloradans with disabilities. These investments have likely contributed to the significant growth in Colorado's LTSS spending since 2018, though may have also supported its strong performance on quality measures, something, when we're talking about performance, which should not go ignored. In 2023, I'll call out Colorado ranked 5th nationally in terms of overall LTSS performance, according to the National AARP LTSS State Scorecard. If you look at the figure on the right of this slide, it places Colorado's LTSS spending in context with a number of other peer states or comparator states, as we call them. Many of them have fee-for-service LTSS programs. Some of them have delivery systems unlike ours, but all of them hopefully give you a flavor together of where Colorado's spending, how Colorado's spending on these services compares over the course of time. Colorado's LTSS spending has outpaced most of these states. Between state fiscal year 2024 and 2025 alone, LTSS spending increased by 20%. And 92% over the full period. Its spending growth has primarily been driven by spending on select waiver services, developmental disabilities, children's extensive supports, and state benefit plans, long-term home health. It increases in LTSS base wage rates and provider rates likely also contributed to this growth, including implementation of the Joint Budget Committee hourly wage increases for HCBS direct care workers and HCBS rate increases. Many of these increases, or portions of these increases, have been suspended in recent months as the state assesses how to manage sustainably Medicaid cost growth. Colorado's investments, again, have resulted in strong performance and by other measures have placed it on par with some comparator states in terms of a state share of total benefit spending, as we mentioned before, and spending per recipient. HCPF is already starting to take actions, as mentioned, to curb some of this growth, and looking forward to talking about potential policy actions in this area as well. If we can go to the next slide on PBT. Health First Colorado's PBT services are available for children with and without disabilities that meet early and periodic screening, diagnostic, and treatment, or EPSDT, medical necessity criteria. Similar to other states, Colorado has seen dramatic growth in PBT spending in recent years. PBT spending grew rapidly between state fiscal years 19 to 25, the period we're trying to kind of stick with, at least through the course of these deeper dive analyses, with annual spending per recipient nearly tripling over the period. PBT service spending now comprises 2% of Colorado Medicaid's benefit spending at around $287 million. A nearly 10-fold increase since state fiscal year 2019. Evidence suggests that spending increases are driven by increases in the number of hours of PBT services utilized per recipient, increases in provider rates, and increases in the number of PBT providers that are responding to this demand throughout the state, which is both increased access as well as utilization. It is also worth noting, and there is evidence of this, that there are indications of healthcare financialization within the PBT delivery system in Colorado and frankly nationally, particularly among private equity-owned providers, which could be contributing to cost increases. There has been a notable increase in the share of PBT recipients receiving more than 10 hours of services per week. And just to continue the financialization point, according to HCPF data, 4 private equity-owned providers accounted for nearly half of this increase. While we cannot directly compare PBT spending across states, Other states are also experiencing significant increases in utilization and spending. Colorado is already collaborating with other states via the National Association of Medicaid Directors to explore the role of private equity in PBT spending growth and devise actions that can be taken both within the state and potentially across states. HCPF also isn't waiting to take action and is already, as many of you might know, has taken steps to reduce PBT provider rate increases introduced in 2024 and has implemented additional requirements related to provider qualifications. If you go to the next slide, a Medicaid cost growth conversation in this country is not would be lacking without a conversation about pharmacy. Many states, in addition to Colorado, have identified concerning trends related to growth in pharmacy spending, particularly relating to specialty drugs. Post-rebate prescription drug spending in Colorado exceeded $680 million in state fiscal year 2025, amounting to 5% of total benefit spending. The figure on the right side of the graph places Colorado again in context with many peer states or comparator states. We found that post-rebate pharmacy spending in Colorado grew less than spending in most comparator states during this period. But I do want to lift up some data that we have from inside the state around specialty drugs. Specialty drugs has been identified as an area of concern for many Medicaid programs across the country, and Colorado's post-rebate spending on specialty prescription drugs has increased 121% between state fiscal year 2019 and 2024. To give you hard numbers, in 2019, $194 million were spent on specialty drugs. 2024, we're talking $430 million. They accounted for only 2% of drugs dispensed, but nearly 50% of drug spending. HCPF has started to take steps to mitigate high-cost specialty drug spending, including joining the Centers for Medicare and Medicaid Innovation, or CMMI's, cell and gene therapy model, carving drugs out of outpatient hospital payment bundles, collaborating with Colorado's Prescription Drug Affordability Review Board and Advisory Council, and executing value-based contracts with manufacturers. If we go to the next slide, you will hear consistently throughout the healthcare conversation nationally, when we're talking about any part of the healthcare affordability conversation, the concern around hospital spending. But despite being a major cost center, specifically within Medicaid, and further specifically within Colorado Medicaid, Colorado's hospital spending has actually grown slower than overall Medicaid spending in recent years. I'd encourage you, when you do see the deck, just to go back to look at that cost center and cost driver set of pie charts. But Colorado's total hospital spending grew about 33% between state fiscal year 2019 and 2025, where it now exceeds $3.3 billion. This 33% growth rate, while significant, compares with a 67% increase again in total Medicaid benefit spending over the period. There are multiple modes, just to kind of unpack how hospitals are paid for ongoing reference, in which hospitals are paid, and which have increased at different rates over time, and which I want to acknowledge. None of those, however, have outpaced overall Medicaid spending growth. Inpatient hospital-based rates were rebased in July 2023. This does not appear to have resulted in dramatic increases in overall Colorado inpatient hospital spending. Supplemental payments comprise the greatest share of overall hospital spending in Colorado, though again, these payments are table or exempt, first of all, and funded by provider fees rather than general fund, and again, aren't really exceeding the overall Medicaid benefit spending growth trend. The figure on the right side of the slide shows trends again in Colorado's inpatient hospital spending over the period. And I just want to reemphasize, growth in Colorado's inpatient hospital spending has mirrored trends in other states, and its overall inpatient hospital spending per enrollee, not shown, is in line or in some cases lower than other fee-for-service states. Those were examples of some of the deep dives that we did in coordination with the state, providing an external objective lens on several key cost drivers or potential cost drivers within Colorado's Medicaid program. Before I close up here, I wanted to take on the next slide a step back and actually address a key question that has come up again and again and again in Colorado. The key question, of course, is whether Colorado should consider changing its Medicaid delivery system to comprehensive Medicaid managed care. To address this question, Manat reviewed available evidence, research on where managed care can bring value to states, considering levers managed care plans commonly used to derive value for states and beneficiaries, and compared those dimensions to Colorado's program as it currently stands and performs. Medicaid managed care, just to lay out a couple of the dimensions on this slide, and then I'll talk about our takeaways and our assessments. Medicaid managed care, based upon the research, of which we hope there would be more than we actually found, is generally associated with positively associated with lower service costs. Specifically, studies on inpatient and outpatient hospital spending on Medicaid managed care identified cost savings. There's also some evidence that Medicaid managed care can positively impact preventable emergency department utilization. There's mixed evidence on managed care's impact on drug spending. The literature has not really shown managed care to have a significant impact on budget predictability. And there is little evidence that we found to suggest that Medicaid managed care decreases overall state Medicaid spending. And some states have actually seen increases in administrative costs associated with the transition to managed care. Studies on the impact of Medicaid managed care on quality across a variety of measures are mixed. Common levers used by Medicaid managed care plans to control costs and increase value include population health management, think risk assessments, care management, as well as utilization management. These, I will note as a segue into the next slide, can also be well deployed within fee-for-service states, including in Colorado. After evaluating available evidence, Manat determined that transitioning to managed care is not likely based upon everything that we've seen in the available literature, evidence, everything we've seen in Colorado so far is not likely to generate significant savings for Colorado at this time. While a significant portion of Medicaid costs, available data does not indicate that Colorado is an outlier in its total hospital spending growth or its hospital spending per enrollee relative to other fee-for-service states. A key component of assessing managed care efficacy, where hospital spending, as we previously discussed, is a major component of overall Medicaid costs. Colorado, when we're talking about cost of avoidable care, Colorado performs at or better than the national median of indicators of costly avoidable care, such as readmissions for adults, ED visits for children, and chronic disease burden. Colorado has invested in population health management through its ACC program and is assessing an increasing use of its utilization management, derived from much of the data that's been presented and elevated through this report and its related research, and which we'll be talking about further in subsequent stakeholder conversations. I'd also like to take a moment to talk about administrative service costs. Colorado's Medicaid administrative services spending, including the state and the RAE administrative spending, totals compared favorably to Medicaid managed care. If you total up the state share, which is less than for administrative spending, which is now be less than 4%, and then the RAE spending, it takes it a little bit above 5% or 5.7% of total program spending. This compares to managed care states an approximate 9.4% of spending on total administrative service costs. Again, based upon available evidence and data, we find that RAIs perform key value-generating functions under the current delivery system. Core methods and interventions of managed care are already in place in Colorado. Sustained utilization management authorities are critical to support medical necessity and program sustainability. And that's not to say that there isn't room to continue building on many of these programs and exercising authorities that the state might have available to it. But we did want to ask and answer that question, knowing that it's one on many minds. And I also know that's not the only question on many minds, seeing a flashing Q&A screen up here. So why don't we, Barrick, if we want to go to the Q&A slide, take a couple of those questions.
Absolutely. Thank you, Kevin and Melinda. Really appreciated that presentation. And I can see by the 60, 70 plus questions rolling in, there's a lot of people who really appreciate this opportunity. We're going to focus on some questions for Kevin and for Melinda, but we also have Director Binsteffer and other members of HICPUF here available. Kevin, I'm going to give the first question to you, and we have a participant who would like to know how you selected the comparator states.
That's a great question, and it is a really good question, and one we spent a lot of time thinking about and talking about as an integrated team with the state. We worked with HICPUF and the governor's office to select comparator states with both like and unlike programs and delivery systems. In many cases, our ability to compare across states was limited by data availability. Just one example, when we were talking about the CMS 64 reports, where we really lean on national and federal data sources to look across states, you are able to break out data to a much more granular level when you're looking at fee-for-service data. Not every state has a program that leans heavily on, like Colorado, on a fee-for-service delivery system. So while we have our ideal kind of set of comparator states, we do also have to work within the confines of data availability. But we sought to, again, keep as broad a spectrum of comparator states as possible. And you'll see throughout many of our figures and data that we put out there, we also try to indicate national or comparator state means or medians wherever possible.
Thank you, Kevin. And I know we'll do a brief overview of the policy options, but Melinda, somebody did have a question for you, or I think you'd be great to answer this. Is there a magic bullet coming out of this analysis by Manat that helps the state find $500 million in savings or $1 billion in savings? Or is this analysis verifying the state's path and identifying smaller but important opportunities to curb Medicaid trends?
Yeah, there is no magic bullet. I think we all wish that there were. But as I said, when I talked about the different levers, you can take a hatchet to the program and damage its underlying purpose, or you can take a scalpel and really look for value in the program. And that's what we're focused on, is how do we find value in the program that brings efficiencies to it. We're going to talk in a minute about the methodology that we're deploying to identify some of those policy options, but I want to set expectations. There's no one magic thing that we can find that Colorado can do to solve its problem overnight.
Thanks, Melinda. Adela, we've got some questions about some programs. A couple of people were not familiar with NEMT and wonder if you could clarify what that is.
Sure, thanks. This is Adela Flores-Brennan, Medicaid Director at the department. And the non-emergency medical transportation benefit is a benefit for the vast majority of people who are on Medicaid. It allows them to get transportation to their provider for any covered Medicaid service. So that program saw a lot of growth in the last couple of years as a result of some fraudulent activity. And we have been able to help to control that activity through restricting provider enrollment, and also by doing some additional work to credential and investigate some of those providers.
Thank you, Adela. Kevin, we were talking about comparator states, and there's a specific question that I'll throw at you. How does Colorado compare to other states, specifically on growth around behavioral health?
That's a really good question, and one that again like brings us back to the data limitations question, or point that we were making. There isn't real reliable national data on behavioral health spending across states, although many states are actually investing in different measurement programs to start to develop behavioral health spending measures and targets across the country. We don't have that comparable data in Colorado yet.
Melinda, we were just talking about the fact that there is no silver bullet. Some folks would like to know, what was the process you used to start developing some of the policy options that you're going to share?
Yeah, and we'll get to that in a second, Barrick, but at the highest level, we started with the data. We looked where there was evidence that there was something happening that was unusual in Colorado, where it looked like either the underlying cost or the cost growth was out of line with what we saw elsewhere. Then we went under the hood a bit and looked at Colorado data specifically to try to understand what was driving that. Sometimes there were clear explanations. For example, when Kevin referenced the decision to increase direct care workforce wages. Sometimes there were less obvious drivers behind that. So our next phase was to try to understand from the Colorado data what was really driving some of those underlying costs and cost growth trends. And then we looked at the policies. We said, so how is Colorado running that aspect of the program? It looks to us like this is an outlier, and we see something that's different from a operational and cost perspective. What are the policies that sit behind that? And what do we know about what best practices are around the country and how that compares to the way Colorado's running its programs? And then we also looked at what's Colorado already doing. Some of the things that we saw, as Kevin referenced, have already been identified. There are already solutions in flight. Solutions that we looked at and said, yep, that's what we would have said as well. So we tried to look at places that hadn't already been addressed in current efforts by the state. And that narrowed our list. It was kind of a funneling down process. And we'll talk a little bit more about then what guided our decisions around which of those policies and areas were worthy of continuing to focus on in a minute.
Thanks, Melinda. I know we'll get into that in just a minute. Kevin, for you, are you able to segment primary cost growth within physician and clinic services?
No.
That one
I would
takes
like
care of it?
to, but states are investing again, like similar with behavioral health, because so many states have this question of trying to get an understanding of where costs are being driven within our increasingly unaffordable healthcare system. New measures are being developed across states, but we don't have that data.
Director Ferrandino, I've got one for you that looks at things more from the state level. We know that Tabor is a big reason that Colorado, unlike other states, can't raise enough funds for things we need for our lives. What can be done about that foundational problem?
Yeah, thanks, Barrick. And I think Kevin raised this point earlier in his presentation about Colorado is uniquely positioned, unfortunately, given our high relative per capita income, which lowers our FMAP, and our limitations put on through the Tabor cap that limits that. We have tried, and the governor has supported several. Sorry, my watch is talking back to me. Several times at the ballot to change, whether it's to de-Bruce or get rid of the cap at the state level. That has not yet been successful. I know there are continued to be conversations on different policy options to whether either raise revenue or adjust the cap at the legislature. And so, we are considering those and looking into those to see. Ultimately, all of those questions come back to the voters who have to decide that. And so, in my role, we have to continue to, unfortunately, deal with the rules as they are set right now. And then, I think open to those conversations, and we are actively engaged in those conversations with legislators.
Thank you, Mark. Kevin, I'm going to come back to you, and this gets more into a process question or methodology. The chosen years of analysis include several outlier years during COVID. What does the data look like if you know when you remove some of those years?
if you remove the COVID years.
Yeah.
Yeah, so that's it was it is a great question. It is a question that comes up in virtually every data analysis we do for almost every topic we do it in. Like, how do we deal with the extraordinary time of COVID, which impacted our healthcare system, and how individuals interact with our healthcare system? We tackled that question from the beginning, and it's why you actually see such an extended period of time across so many of our analyses, baselining a lot of these trends in 2018, 2019, and then carrying both through the public health emergency and those funky years, and then coming out the other side. I mean, as you will see through a lot of those trends, the trends are in cost growth are sustained, and again, we tried to provide that longer term picture to verify um, that they are consistent.
Great. Thank you, Kevin. And I'll stay with either you or Melinda on these next couple. Continue to look at what data was analyzed and some of the reason why. When comparing administrative costs as a percent of the spend, were the managed care states Medicaid expansion states?
So I don't know the answer to the question. Kevin, do you know that? The states where we came up with our 9%, I think we'd have to go to the original source on that to pull which states that were.
Yeah,
Um,
I believe it was all Medicaid managed care states in that calculation. We
No,
can
expansion
verify.
states is the question. Were
Yes.
they also expansion states? I believe the majority of them were. I don't know if all of them were, but we can go back and look at the original source on that and get back to folks.
I appreciate that and appreciate you letting me throw you some curveballs. In terms of looking here in Colorado at what was analyzed, were the two MCOs, which would be Denver Health and Rocky Mountain, was their data included in this analysis?
Yes, their data was included in this analysis.
It would have required us pulling it out. We were looking at overall numbers, so we were not zeroing in on individual providers in the analysis.
Scrolling through some of our questions here. One moment. Adela, a question for you. We talked a little bit, you were explaining what NEMT does. Someone was asking about the fraud that was alleged there or was found. And are we excluding the fraud that was found in it? So do we have a full, accurate picture of this?
So the costs that are represented do include the costs with the fraud in there, because as at the end of the day, we did spend all of that money. Now we have made really concerted efforts to go after those providers who defrauded us, and we've been working with law enforcement at both the state and national levels to be able to do that. Just by putting into place some stricter provisions around credentialing and validation, and limiting who we have in our network, we've been able to really control that cost curve over time.
Question for the Manat team in terms of the states that were looked at. Somebody's questioning, should we be comparing Colorado to California in this analysis, or is there a reason not to? Somebody suggesting that Colorado may look more like Colorado than a state like Idaho.
Yeah, I think what we went through a deliberative process with the state again to pick delivery systems and peer states that both looked like the delivery system in Colorado, particularly for those individual service areas, as well as we picked a few states where data allowed us to look at disparate delivery systems. Melinda, I don't know if you had anything else to add on that one.
No, I mean, the thing is we also looked at national trends. So we did try to look at this from multiple angles. And as I said before, this was at the top of our funnel. So this was really our first layer, like where's their smoke? And then we click down, where's their fire? And then where's something we can do about that fire? So we did spend quite a bit of time thinking about comparator states. I think we all could have made arguments for adding more or different, but I do think we at the end felt like we had some real integrity in the process and in terms of representation across national trends and comparator states.
Director Bimsteffer, there's a question about what's being done to reduce pharmacy costs.
Thanks for the question. So, as we all know, the generic drugs are pretty flat at HICPA for the last 6 years. It's the specialty drugs, high-cost specialty drugs, that are really the driver, and that's the leading cost of national healthcare cost, is these high-cost drugs. So the first thing just to realize is the best way to control that is the federal government steps in, and before a drug comes to market, you have to negotiate the price like every other nation does. The second is to eliminate or to mitigate the amount of patent extensions that manufacturers can get. Those are two most important things. Outside of that, which are outside of our control, we've done a bunch of things. So as Manat said, less than 2% of the drugs are driving 50% of the costs. So that's the specialty drugs. So one, rebate management is really, really important, and our team is really good at that. There's no middleman. We do all that directly. We sign the contracts directly, and I think we do a better job overall. As you could see, our costs were lower than the rest of the nation. So thank you, HICPA pharmacy team that does that. To negotiate value-based payments on these high-cost drugs, which holds the manufacturer accountable for their clinical promises. So if they say this really expensive drug is going to do A, B, and C, and it doesn't, we want some of that money back, and we want lower prices on the upfront. So we're doing that. I think we're up to 10 now, these really high-cost drugs. Utilization management, really important. Right drug, right condition, right outcome, right cost, right setting, really good. We've had some reimbursement logic adjustments, but that's been a minor part. The prescriber tool has been really important, and it's been wildly successful with almost 70% of prescribers under Medicaid now using a tool that helps them see various drug prices that they can say, oh, I didn't know this one was lower than that one. And if they like the clinical effectiveness, they have the ability to do whatever they want. But they now have insights into the top 3 drugs that might be more cost effective, and they can also do the prior authorization electronically and quickly. So that's a win-win-win-win for everybody. So we're doing a lot, but the Fed has to step up and do a lot more. And whatever the PDAB does, the Prescription Drug Affordability Board, we can go along for the ride, but traditionally, Medicaid drug prices have been parallel with other countries except for these high-cost drugs that, again, are the biggest part of the problem.
Thank you, Director. Kevin, back to you. A question about what we can do. Can the rising growth in spending be more about population growth, the facility and the provider billing costs, and sent to Medicaid knowing they will get paid more that's with private pay? Somebody says, we as consumers have no choice in these fees and bills to negotiate. So wondering about some of these contributing factors and population growth and the facility and provider billing costs.
From my experience working with cost growth nationally, I think that there are many factors that drive cost growth in Medicaid programs. Population is one. Population composition is another. Services being delivered and the composition of those services, coding practices are others. And it's up to many states like Colorado to have checks in place to ensure the integrity of those bills being rendered. And I think that many of those programs are in place in Colorado, but continue to be strengthened.
And this may be more for the HICPUF team, but a question about whether HICPUF and or Manat will make any of the data behind this assessment and some of the conclusions available in what's being shared publicly.
I can take some of that and then throw it over to Adela. So largely what we've handed to Manat is information that we have publicly available, like what's included in the ACC and what are the solutions that we have on utilization management, or the massive data that we've been sharing on what's the trend per person per month, paid trend for 6 years. We just finished and added in 24-25 for Manat as they did their analysis. But as we go through the JBC hearings, we'll continue to share more of all that data in a public setting. Adela, what did I miss there?
No, I think that's right. And as the team showed at the beginning of the presentation, a lot of the data sources that were used are public data sources. So There is a lot of analysis, though, that went into that, and a lot of nuance that goes into evaluating some of those data sources, especially when you're comparing across states. So as we move into the new year, we are going to be putting out a lot of this information, including this deck and the recording of the webinar, but also a more comprehensive deck of information that goes through this landscape analysis and other policy options.
Thank you,
Adela.
Adela.
So we're going to put that out there, but then Barrick is on point to stakeholder that, right? So there's a whole process coming out. You want to just hit that a little bit more?
Yes. So as we move into the new year, we are going to be continuing a stakeholder process. This is, again, just a webinar to introduce the work that we've been doing. I think people were generally aware that we were undertaking this analysis. So we wanted to make sure to communicate it out to folks. And then as we move into the new year, we will start having more targeted engagements so that we can solicit feedback and have more of a dialogue with our stakeholders.
Thanks, Adela, and we'll cover that as we close up. I appreciate all of the questions. We've captured every question that was submitted, and that will be incorporated as HICPUF plans some future communications into the new year, including those stakeholder engagement opportunities Adela mentioned, and some Q&A that we'll be sharing, or FAQs down the road. At this point, I'd like to wrap up this portion of the Q&A. Thank everybody who jumped on for it. We're going to bring the Manat team back in to do a quick overview on some of the policy strategy conversation. Kevin, Melinda?
That's me. Thank you. And I just wanted to note one of our team members did pull the original source and confirmed that the comment on the estimated cost of administrative costs inclusive of Medicaid managed care states included both expansion and non-expansion states. That was a Milliman report that was published in July of 2024 that we were relying on there. Okay, so now the last section here. We're going to talk about what's next in our work. So let's go to the next slide, please. Thank you. So from the analysis that Kevin walked through and from discussions, as I said before, with HICPUF and the governor's office, where we looked at what under the hood of these different trends, what was driving them, what do we know about them? And then we started to look at what potential opportunities are there for policy changes that could help address outlier trends that have not yet been implemented by the state. We settled on 4 major areas of focus for identifying policy actions. The first was behavioral health, the second LTSS, the third pediatric behavioral therapy, and the fourth pharmacy benefits. To the extent that there are already actions underway in each of these buckets, and there are, we are not going to focus on them, Manat. We are aware of them. We've communicated, many of them are best practices that had they not been happening, we would have recommended, but we're trying to look for additional areas of policy change that can bring value to the program. Let's go to the next slide, please. We established some goals, some kind of guardrails for our work in this area as we looked at policy actions. What makes a policy action desirable or something that the state would consider. And we came up with the following 5 guiding goals. The first is cost savings. We are trying to realize program efficiency. So we are looking for areas of cost saving. The second is feasibility. Can the state do this? Is this something that the state has the resources to do? And that it's realistic that we'll be able to realize this change without overburdening the state or without setting ourselves up for failure. 3, long-term sustainability. We're not just looking for a quick one. We are looking for things that will produce savings quickly, but not just quickly. We're looking for things that help sustain the program over time. 4th, we really want to prioritize member health and experience, and that's been core in all of our discussions. At the end of the day, the Medicaid program is there to ensure access and coverage and quality care and a positive member experience. So really thinking about implications of potential policy actions on the member experience has been central to the discussion. And then finally, what are the impacts on the delivery system? We want to minimize negative impacts on the delivery system so that we know that our program is operating on that solid base of providers, and that feeds into obviously the access and quality issues we talked about before. So those are the principles that we were kind of the guiding goals that were that we kind of held up as we looked at our different policy action areas. And let's go to the final slide. Here is a very high level overview of the preliminary policy actions that emerged from this first stage of the process. The first policy action here is around withdrawal management. Inpatient withdrawal management is not clinically indicated for all substance use, forms of substance use. So the goal here would be to identify where it's appropriate to shift to other alternatives, outpatient alternatives for substance use, where there's a clinical evidence base that indicates that's a more effective and more efficient mechanism for addressing withdrawal management needs. The second area is around tiered pricing for select behavioral health services. Colorado identified areas where flat pricing was being applied across levels of widely varying acuity. And so the goal here is to identify where tiering may bring more efficiency within the program and enable the enrollees to ensure they're getting access to the appropriate level of care with an appropriate reimbursement rate. The third area is around mobile health services. The idea here is that Colorado would expand mobile health, which is an evidence-supported intervention. It's both has been shown to be both cost savings and improving access and health outcomes. So one of those win-win scenarios. The goal here would be to improve access to non-crisis physical and behavioral health services. And Colorado's already had an operational base for mobile health and the authority to add coverage to these services. So we felt this was a potential high value area. The fourth is in the LTSS space. There's evidence that provider behavior is making it harder to ensure that members get to the right level of care for their needs. So the goal here would be to deploy multiple strategies that could help oversee providers and educate members. The idea here is that you would be strengthening the strengthening rules around direct-to-consumer advertising, case management oversight, and consumer and provider fraud prevention education. These are all tools that states have used to try to better ensure program integrity and connect consumers to the appropriate and most efficient care. Our next big bucket here is around pediatric behavioral therapies. As Kevin mentioned, this has been an area of exponential growth within the state and in many states. The goal here would be to create standardized assessments that would support clinically informed and individual treatment plans that are based on sound clinical criteria. Again, really to ensure that members are getting the right level of service that's most clinically appropriate for their needs. Given the broad nature of ASD diagnosis, assessments are essential to calibrate the treatment and interventions. And so this would be an effort to try to create more standardization in that area. And then our final is around modifying protected drug classes. The idea here would be that Colorado would implement responsible utilization management strategies for select specialty drugs and high-cost drugs, increasing rebates and addressing recent cost growth. The precise mechanics of this will vary depending on the class of drugs, and that's an area that we're still exploring. I understand that what I've just described are very high level. That's a reflection of where we are in our process. An important part of continuing to iterate and dive deeper on each of these areas is going to be stakeholder feedback and input. We wanted to put them out there so that they're on your radar screen, acknowledging that they're fairly broad. With that, let's go to the final slide here. We are very excited to have the partnership with Barrick on the stakeholdering here. It's going to be really important to our process going forward. And I'm going to hand this off to Barrick to talk about our next steps.
Wonderful. Thank you, Melinda. And as folks see on the slide, slides and materials from this presentation, together with a recording, will be made available on HIPPU's website. And Manat will also be sharing the findings of their landscape analysis at an upcoming JBC hearing meeting on January 5th. Starting in the first quarter of next year, as Adela mentioned at the top, as well as Director Bimsteffer, we'll be engaging in a number of opportunities to hear from all of you and to hear from stakeholders as we start digging more into those policy options. I recognize we were not able to get to nearly all of the questions today. We have almost 100 questions that were submitted. We have captured all of those, and that will inform both what we come back to share with all of you and some of the documents that HICPUF is developing. But today is really just the start of this conversation. People were aware of this process underway, and HICPUF and the state wanted to take this opportunity to share that analysis with all of you, to do some level setting so that we can really engage with all of you in some of the conversations about both the short term and the long term going into next year. So we would ask you in closing to keep an eye on that website for those materials getting posted and for upcoming opportunities to engage, which will be continued to be shared through all of the usual channels. But on behalf of Director Bimsteffer and the entire HICPUF team, Mark Ferrandino, OSPB in the governor's office, and the Manat Health team, thank you all very much for spending some time with us this afternoon, for the engaging conversation, the questions, and we look forward to seeing you in 2026 as we have more opportunity to have some more robust conversations with all of you about how we navigate this together. Thank you all and have a fantastic holiday season.